The topic for today is acute glomerulonephritis, or the acute nephritic syndrome, and during the course of this lecture we'll be discussing the definition of acute nephritic syndrome. We'll be dealing with the etiology, the common etiologies, and subsequently we'll be moving on to the most important etiology of acute glomerulonephritis, which is post-streptococcal acute glomerulonephritis, and the rest of the lecture will basically deal with post-streptococcal acute glomerulonephritis. We'll be touching on pathophysiology and finally moving on to the clinical aspects of AGN and ending with the outcome. So, to start with a definition, acute glomerulonephritis can be defined as a condition with acute glomerular injury which is accompanied by hypertension, hematuria, proteinuria, oliguria, peripheral edema, and deranged renal function. So basically patients present with all these aspects and it is with them that you would suspect acute glomerulonephritis. Etiologically, the most important entity is post-infectious acute glomerulonephritis, or infections which lead to AGN. And even in the infectious entity or the post-infectious entity, the majority, or more than 80%, are due to group A beta hemolytic streptococcal infection. Other important post-infectious causes are bacteria like Staph aureus, Strep pneumoniae, Mycoplasma, and E. coli, viruses like EBV, CMV, herpes simplex, hepatitis B and C, and varicella, parasites like malaria, schistosomiasis, fungi like Candida and Aspergillus, and rickettsial infections. All these can cause an AGN-like picture, but as I mentioned, the most important entity is group A beta hemolytic streptococcal infection. Other etiologies that present with a picture of acute glomerulonephritis or acute nephritic syndrome include systemic lupus erythematosus, or SLE. Henoch-Schönlein purpura with the rash can present with an AGN-like picture. IgA nephropathy also is known to, though they usually present with macroscopic hematuria which is recurrent, they can present with an AGN-like picture. Membrane proliferative glomerulonephritis, or messenger capillary as the English call it, this type of nephritis too can present with an AGN-like picture. The ANCA-associated vasculitides, they usually present with a very atypical, very rapidly progressing picture, but they can present with AGN as well. And also shunt infections in patients with known patients with shunts like BT shunts can have shunt infection, and that can lead to an immune-mediated acute glomerulonephritis. Acute infective endocarditis also can present with a nephritis-like picture. So all these entities are very, very important to keep in mind, but again I reiterate, the most important entity is acute post-streptococcal glomerulonephritis, which we will be dealing with during the subsequent course of this lecture. Epidemiologically, as I mentioned, and I kept on mentioning, it is the most common cause of acute glomerulonephritis globally. There are an estimated 470,000 annual cases worldwide, and out of this 97%, or the very vast majority, occur in developing countries due to overcrowding and the spread of streptococcal infections. The annual incidence is 9.5 to 28.5 per 100,000 population, which varies markedly with the area in which the patient comes from. and the incidence in developing countries, in developed countries rather, has decreased very markedly over the past 3 decades, as has the incidence of rheumatic fever. But it still is a problem in developing countries. What are the host factors that are important when considering a patient with acute glomerulonephritis? AGN, or acute glomerulonephritis, occurs in children mainly in the school-going age, 5 to 12 years, and only about 5% occur in children less than 2 years. This is because the streptococcal infections are common in the school-going age group. Male to female incidence is 2 to 1, and the socio-economic background is also important. I touched on this in the previous slide. So it is an infection associated with overcrowding. So this is really usually associated with the poor socio-economic status. There is a genetic predisposition to acute glomerulonephritis, and these HLA typings, HLA-DR1 and DRW4, have been found to be more susceptible to AGN, and DRW48 and DRW8 have been found to be less susceptible to AGN. What is the site of streptococcal infection? Now, it can be the upper respiratory tract, usually pharyngitis, which is the site of infection, and out of these, out of the strains that cause pharyngitis, nephritogenicity has been found in the strains that I've mentioned here. In the streptococcal strains causing skin sepsis, 49, 55, 57, and 60 have been found to be nephritogenic. Right, let's move on to the pathogenesis and pathology of acute glomerulonephritis. Now, the initial step following a streptococcal infection is antibody formation by the body against streptococcal antigens. This can lead to antigen-antibody complexes forming, and these circulating antigen-antibody complexes can get deposited or trapped in the glomeruli. There can also be molecular mimicry between the streptococcal antibodies. There can also be molecular mimicry between the streptococcal and the streptococcal antigens and the renal antigens, and the antibodies formed against the streptococcal antigens can attack the renal antigens because of molecular mimicry. And there can also be in situ formation of anti-streptococcal antibodies with the glomerular antigens. So all these entities lead to an inflammatory cascade and complement activation, and this gives rise to quite significant glomerular inflammation, but the inflammation pathologically is described as a diffuse proliferative glomerulonephritis, where the entire glomerulus is involved in the inflammatory process. So, what are the histopathological changes? Now, this is a normal glomerulus, and you can see in stark contrast in a patient with post-streptococcal glomerulonephritis, which the second picture shows, you get a diffuse proliferative glomerulonephritis. So it's diffusely, the glomerulus is diffusely inflamed. You can see there is an increase in both the mesangial matrix and the cellular component. It looks crowded. When compared to the normal glomerulus, and this leads to this leads to blockage of the glomeruli, and the inflammation leads to blockage of the glomeruli, which gives rise to the clinical features. There is an immunofluorescence slide of a patient with post-infectious glomerulonephritis. Again, you see diffuse. This has been stained for complement, and if you can see that the complement is deposited diffusely, showing diffuse inflammation of the entire glomerulus. IgG is also, if you stain for IgG, it would give a similar picture with IgG deposited over the entire glomerulus. What are the physiological changes, rather? So we dealt with the pathology and the pathophysiology, and the glomerular inflammation that I just showed you leads to a reduced glomerular filtration. So the glomeruli get clogged and they do not filter. They stop filtering, and that itself leads to volume overload because the urine output is diminished. And inflammation of the glomeruli also can lead to renin-angiotensin-aldosterone axis activation, and RAA axis activation, as you all know, leads to avid salt and water retention. And because of this, these patients are in an overloaded state. So there is reduced glomerular filtration caused by the inflammation, as well as RAA axis activation, which both lead to a volume overloaded or fluid overloaded state. So what are the clinical features in a patient with acute glomerulonephritis? Now there can be, as we said, it occurs following a streptococcal infection. So there may be a history of preceding streptococcal infection. Now this can be skin sepsis, due to the streptococcal skin sepsis, and this can occur up to 6 weeks prior to the onset of acute glomerulonephritis. There can be evidence of pharyngitis or an upper respiratory tract infection. This occurs closer to the nephritis, and it usually precedes the nephritis by about 1 to 3 weeks. So this history is important to obtain, and that would basically give you a clue as to what the cause of the nephritis is. The patients present with the nephritic picture, which includes hematuria, oliguria, edema, and hypertension. So they will have macroscopic hematuria usually, but sometimes it may just be microscopic. There will definitely be a reduction. There will be a reduction in urine output, and that would lead to edema because the patient is not passing adequate amounts of urine. He will be overloaded, and that would lead to edema and hypertension. The patients may present with the complications of the disease. So the complications of fluid overload can be significant hypertension, which may lead to even hypertensive encephalopathy. So they can present with hypertensive encephalopathy or seizures, and acute hypertension can also lead to heart failure. So the presentation again can be with the complication of heart failure. But always, in any patient presenting with features of acute glomerulonephritis, hematuria, oliguria, edema, and hypertension, always look for non-post-streptococcal features of non-post-streptococcal AGN. Now this is important because post-streptococcal AGN usually does not require any specific treatment. It's just a symptomatic and supportive treatment that you require, but the other entities causing acute glomerulonephritis like lupus and mesenteric capillary and IgA nephropathy, they all need specific treatment usually. So the differentiation between post-streptococcal and a secondary cause or other cause of nephritis is very important. Right. What are the investigations you do in a patient presenting with the nephritic syndrome or with hematuria, hypertension, edema, and oliguria? What are the investigations you do? So these are basically the investigations that you do in any patient, but in patients presenting with an atypical or presenting atypically, there are other investigations that you probably need to do. So the full blood count will usually be normal because because it's a post streptococcal acute glomerulonephritis or a post streptococcal infection. So there is no active streptococcal infection at the time of AGN, so it usually will be normal. But because of the fluid overload or the water retention, you might see a dilutional anemia. Because of the volume overload and dilution. However, if the patient if the AGN or the nephritis is due to lupus or some other entity, other changes, maybe they are saying lupus, there might be a thrombocytopenia in your full blood count. So the full blood count is important for these reasons as well. Urine analysis is exceptionally important. What will you see? There may be macroscopic hematuria for what you do not need a urine analysis to detect, but the hematuria might be microscopic and evident only on your UFR. The UFR will also show evidence of, because it is quite significant glomerular inflammation. There may be red cell casts and even granular casts, and these two signify quite significant glomerular inflammation. Proteinuria is also evident, will also be evident on your urine analysis, and this proteinuria is usually not severe, or not in the nephrotic range. It is usually less than 3+. It usually is around about 2+, and 3+ would make it slightly atypical. 3+ proteinuria would make it slightly atypical. There may also be evidence of pyuria as well, but not very significant. Your creatinine may be normal, may be slightly elevated in post-streptococcal infection, but there should not be any rapid rise in creatinine, and the creatinine should not be very high. And that, if there is any rapid rise or the creatinine is excessively elevated, these are atypical features. Your electrolytes, because there is acute glomerular inflammation rather, and acute kidney injury, that might show evidence. It might show evidence of hyperkalemia in your electrolytes, and your throat swabs, if you do it, they will generally be negative because, as I mentioned, it's a post-streptococcal inflammation, so your infection has occurred some time ago. The anti-streptolysin O-theta has good positive predictive value, in the sense that if it is positive, it is very significant to make a diagnosis of. It is significant to make a diagnosis of post-streptococcal infection. However, because a lot of the skin sepsis causing strains do not produce anti-streptolysin O, your ASOT may be negative even if the patient has post-streptococcal infection, and the ASOT positivity is only about 50% in patients with post-streptococcal nephritis. So it has a good positive predictive value, but if it is negative, it does not mean that this is not post-streptococcal nephritis. If you add on the anti-DNase B, the sensitivity goes up to about 80 to 90%. So it's an important investigation to do because it helps in the diagnosis. But if it is negative, it does not preclude diagnosis of post-streptococcal nephritis. And that is important to keep in mind. Your complement levels are not available freely in all hospitals. We have it, so we do it, but it's not essential to do because it is an expensive investigation. But if you do have the facility, certainly the complement levels are very, very helpful. And what is usually seen in post-streptococcal infection is a low complement C3 level with a normal C4 level. That is the classic pattern that you would see, but a slightly low C4 level also can be noted in these patients, but mainly it's low C3 with a normal C4. Right, let's move on to management. So by and large, the most important aspect of managing most important thing to remember about the management of post-streptococcal nephritis is that your management is symptomatic and supportive. This post-streptococcal acute glomerulonephritis is a self-limiting condition in the vast majority. You do not need specific treatment. All you need is symptomatic and supportive treatment until the nephritis resolves on its own. So that is extremely important to remember, and because you're not doing anything specific to manage these patients, you're not intervening with specific medication, it is important that your diagnosis is correct. So that is why it's always important to look for atypical features. Look for features of lupus, look for features of mesangial capillary nephritis, look for features of other entities like henoxon-like purpura, because those might require specific treatment. But if you have a definite diagnosis of post-streptococcal infection, your management is symptomatic and supportive. So what would you monitor? You need to monitor your blood pressure very closely in these patients, because they will almost always be hypertensive. So you need to monitor your blood pressure a minimum of 3 times a day. But if the patient is hypertensive or significantly hypertensive, you need to monitor the blood pressure much more frequently. You need to have a strict input-output chart, right? You need to, because they tend to have oliguria, you need to monitor the input and output very stringently. And what you would do is you replacing your urine output plus the insensible loss in the following period. So strict maintenance of an input-output chart is needed, because otherwise, if the patient does take too much fluid or your input is excessive, they can go into fluid overload and hypertension. Weight is an important aspect of monitoring, because in small children it may not be, especially if they're breastfeeding. It's usually not very prevalent in very small children, but if they are breastfeeding, or if your input is difficult to monitor, the weight is a very good measurement as to ascertain whether the patient is getting overloaded or not. You need to check your urine albumin daily, the early morning, first morning void, and monitor the degree of proteinuria. You don't have to do UFRs daily, but the urine albumin needs to be checked daily. And you need to check your renal functions at the outset, and also if the patient is not resolving, definitely not on a daily basis, but if the creatinine is tending to rise, you need to do it very, very frequently until the creatinine starts coming down or plateaus. The role of oral penicillin is interesting. Now, this is a post-streptococcal infection, so the patient has already had an infection which has caused glomerular inflammation. So giving oral penicillin to this patient in a treatment dose, which is a 6-hourly dose, is not going to help this patient's nephritis. He or she has already had the nephritis, and treatment of the streptococcal infection is not going to change the course of this patient's or your particular patient's nephritis. But the usage of oral penicillin is important, because if the patient is still harboring the organism, it's not going to help him. Treating the streptococcal infection is not going to help him, but if he is still harboring the organism, a treatment course of oral penicillin, which is 6-hourly penicillin for 10 days, a treatment course will eradicate the organism from the patient, and thereby prevent the spread of a potentially nephrogenic strain of streptococci. So the use of penicillin is basically an act of secondary prevention. and prevention of the spread of a streptococcal strain, or nephrogenic strain rather. Diet-wise, you need to restrict fluid. We said the input would be your previous day's urine output plus the insensible loss. So you need to restrict your fluid depending on the degree of depending on the urine output and the degree of hypertension. If the patient is very edematous, you might need to even further restrict the fluid till you get a negative balance. Because the patients are prone, because these patients have acute kidney injury and they're prone to hyperkalemia, you need to restrict potassium. So fruits need to be curtailed. It's very common in Sri Lanka for any sick patient to receive king coconut water because people have an assumption that king coconut water is healthy for any disease, but here it can kill because king coconut is very, very rich in potassium. So avoid king coconut specifically, and other fruit juices and other fruits and juices and other food high in potassium. And because the patients have salt and water retention, you need to give them a low salt diet till the hypertension resolves. Remember, it is only till the hypertension resolves that you need to restrict your salt. You get patients who have AGN, they've been told to restrict salt, and you follow them up 6 months, and at follow-up 6 months later they're still not taking salt. So that doesn't need to happen. You just need to restrict salt during the acute phase till the hypertension is under control, and not subsequently. So the diet is also extremely important, and because these patients are hypertensive and they are prone to heart failure and hypertensive complications, they need to have bed rest at least until the hypertension is under good control. So bed rest is necessary as long as the blood pressure is high. Just to touch on the management of hypertension, I mentioned the cause of the hypertension is salt and water retention and fluid overload. So your first line antihypertensive should be a diuretic, a potent diuretic like furosemide, to get rid of the fluid. So you've retained fluid which is causing hypertension. Your treatment is to get rid of the fluid to reduce the intravascular volume and reduce the blood pressure. If this does not work, and you do not reduce, then you cannot reduce the reducing the intravascular volume doesn't reduce the hypertension. The next step is to increase the vascular capacity, and that is by a vasodilator. So calcium channel blockers like nifedipine are commonly used as the second line antihypertensive. A word about the use of captopril. Now, we said that hypertension is due to RAA axis activation, so why not block the RAA axis with an ACE inhibitor? The problem with captopril is that captopril, by dilatation of the efferent arteriole, causes reduced glomerular perfusion, and these patients anyway have reduced glomerular perfusion. So if you do use captopril in these patients, you would worsen the glomerular filtration and further reduce further increase the creatinine and reduce the GFR. So captopril should not be used, and also captopril causes hyperkalemia, worsens the hyperkalemia which these patients are prone to. So for these two reasons, the use of ACE inhibitors should be avoided unless the blood pressure is very, very difficult to control, and even then it should be used with a great deal of caution, with monitoring of the renal functions and the potassium levels. So in my clinical practice, I've never had to use captopril to control the blood pressure in a patient with post-streptococcal nephritis. Sometimes there can be severe hypertension with features of hypertensive encephalopathy. So these patients need urgent reduction of the blood pressure to acceptable levels. So here you need to use intravenous hydralazine and labetalol as infusions, so that you can titrate the blood pressure and reduce it slowly to acceptable levels, because you need to control blood pressure if the patient is having features of encephalopathy. So that is basically the management of hypertension in AGN. Diuretics first, calcium channel blockers or vasodilators thereafter. Let's move on to the clinical course. So you actively use diuretics in your management to control the hypertension, but even if you do not use diuretics to control the hypertension, the patient will have a natural diuresis within 7 to 10 days of the onset of the disease. So they will naturally go with the resolution of the glomerular inflammation. There will be a diuresis in 7 to 10 days. The blood pressure usually normalizes within 2 weeks. Rarely it can go on to 4 weeks, but the patient should not be hypertensive more than after 4 weeks. And just to add to that, difficult to control blood pressure exists only in the first 1 to 2 weeks. There should not be difficult to control blood pressure after about 2 weeks, and that would be atypical if there is difficult to control blood pressure at that point. Macroscopic hematuria signifies very significant glomerular inflammation, so this should settle in 1 to 2 weeks, and after 2 weeks there should not be macroscopic hematuria. Significant proteinuria again clears within 2 to 4 weeks, and nephrotic range proteinuria is an atypical feature in acute post-streptococcal glomerulonephritis. Rarely you can get it, but always if you do have nephrotic range proteinuria, you need to be very wary, or you need to look out stringently for another cause, right? And any significant proteinuria should clear, so anything around 2 plus should clear within 2 to 4 weeks. There can be mild degrees of proteinuria, like say trace 1 plus, going on for up to 3 months, rarely, but certainly not more than 3 months. Your renal function, elevated creatinine, we said a lot of patients do have a mildly elevated creatinine. Renal function should normalize by 1 to 2 weeks, and anything sort of a high creatinine after 2 weeks again should be considered an atypical feature. If you have done the complement levels and you have a low C3, this can take up to 12 weeks to normalize. So there is no point repeating the complement earlier than this, because even if it is still low, it is not atypical. And if you're repeating the complement, it should be done after 12 weeks to see whether it has normalized. Microscopic hematuria, for that matter, can persist for 1 or even 2 years, and even at that point, microscopic hematuria alone, if it is not associated with proteinuria, hypertension, or deranged renal functions, that itself is not an entity, an indication to do a biopsy. It only indicates that these patients require further follow-up till it clears, but it does not indicate the need for a renal biopsy. So this clinical course is important to pick, or remembering this clinical course is important to pick what falls outside, and what falls outside is atypical. It needs further evaluation, usually with a renal biopsy, to find out the etiology, because that etiology may not require symptomatic and supportive management only, and that etiology might require specific treatment. So anything outside this box should be considered atypical. Further, it should be evaluated further and dealt with appropriately. Follow-up. We tend to follow these patients up weekly till they are off antihypertensives. We tend to discharge them if the blood pressure is if there is good control of blood pressure for about 48 to 72 hours without any exacerbations. It can discharge them on antihypertensives, but a lot of units would discharge the patient only once they are off antihypertensives. But even if they are not, even if you do discharge them on antihypertensives, you need to monitor the blood pressure, and we would review them in a week and tell them to monitor the blood pressure at the local hospital or locally every 2 to 3 days. Till the proteinuria clears, I said mild degrees of proteinuria can go on for up to about 3 months. So till the proteinuria clears, you need to monitor them monthly, because the proteinuria can rarely see exacerbation, and that would require further evaluation. And thereafter, once the proteinuria and the hypertension have completely cleared, I said that microscopic hematuria can go on for up to 1 to 2 years. So till the UFR sediment is completely cleared, you need to monitor these patients up, and you can space out the monitoring maybe even once in 6 months till your UFR has completely cleared. As I mentioned, microscopic hematuria can persist for 1 to 2 years, and you need to follow these patients up till it has completely cleared, but maybe every 6 months, and you can space it out accordingly. What are the complications? We've dealt with hypertensive encephalopathy. So this, if the patient has fits, you need to deal with it early, but for that matter, the patient should not have fits if the patient is in hospital, because if the patient has developed hypertensive encephalopathy, that means that your monitoring of the blood pressure has been suboptimal. So you need to pick the rise in blood pressure, or pick the patients before they develop hypertensive encephalopathy, and that is why you need to monitor the blood pressure very closely. Look for features of hypertensive encephalopathy like blurring of vision, headache. Some of these patients have abdominal pain, and these are all heralds of hypertensive encephalopathy. So you need to pick these patients, the symptomatic patients rather, and deal with the hypertension at that point before they develop hypertensive encephalopathy. And on examination, fundoscopy with changes can be delayed, but one of the early heralds of significant hypertensive encephalopathy is exaggerated reflexes. So you need to in your morning rounds, or whenever the patient is hypertensive, you need to check the reflexes, especially if they are symptomatic. And if there are exaggerated reflexes, consider that a herald of hypertensive encephalopathy, and it basically denotes that you need to control this blood pressure stringently. So look for features of hypertensive encephalopathy before it develops, because it should not happen. They should not happen, and I would consider it negligence if it does happen in my unit. Look for features of heart failure. So there can be shortness of breath, difficulty in breathing, orthopnea, and there can be basal crepitations if you do examine the patient. So these patients usually can be managed with higher doses of diuretics. Again, you need to pick the patient. You need to address fluid overload before they go into heart failure. And acute renal failure requiring dialysis, again, this sometimes does happen. It would be atypical for a post-streptococcal nephritis to need dialysis. Again, should never happen. If it does happen, it would usually indicate a non-streptococcal etiology. And it is important to note that a very, very minor percentage of streptococcal infection can develop chronic renal impairment. So that is why we tend to follow these patients up, especially the ones who have been proven to have post-streptococcal nephritis, but who have atypical presentations. We tend to follow them up indefinitely, because there is a very minor percentage that do develop chronic renal impairment. So what are the indications for renal biopsy? So I mentioned that post-streptococcal nephritis is a self-limiting condition which requires symptomatic and supportive management. So anything falling out of that box, anything atypical, may indicate another etiology which requires specific treatment. So that is why it's important to pick the patients who have atypical presentations and look for another etiology by doing a biopsy. So if there are features of other nephritides, like the patient presents with features of AGN, hypertension, hematuria, oliguria, and edema, but has a vasculitic rash or alopecia, or oral ulcers, malar rash, features of SLE or henox-online purpura, so then you need to do a biopsy, because you need to see look as to what is exactly going on in the kidney. If the patient has a rapid rise in creatinine, we said that if the patients with post-streptococcal nephritis can have a mild rise in creatinine. But if there is a rapid rise in creatinine, say on day 1 it was 80 micromoles, day 2 120, day 3 180, yeah, you need to do a renal biopsy, because that could indicate a rapidly progressive glomerulonephritis, which needs urgent intervention with methylprednisolone. I said that the creatinine should normalize by 2 weeks. Right? So persistently elevated creatinine more than 2 to 4 weeks should be considered abnormal, and you should do a biopsy to look for another etiology. I would not permit the creatinine to be high more than 2 weeks in our unit. Another important entity is the nephrotic-nephritic mixed picture. Now, some patients present with the features of nephritis, again, oliguria, hypertension, hematuria, and edema, but with nephrotic range, proteinuria, and hypercholesterolemia. So the nephrotic-nephritic mixed picture. Now, this always indicates another etiology. This almost always indicates another etiology. So you do need to do a biopsy. It's a definite indication to do a biopsy. If there is significant proteinuria, anything more than 1+ or 2+ proteinuria at 4 weeks, again that patient needs biopsy. If there's macroscopic hematuria going on for more than 2 to 4 weeks, indicating severe glomerular inflammation, there may be something else going on, do a biopsy. And if your complement is persistently low after 12 weeks, that again would indicate that either a mesenteric capillary or a lupus nephritis. So again, you would need a biopsy. So this is important, because you need to pick the patients with atypical presentation, because they might require specific treatment. So we will end there. So I hope you've got a glimpse as to what post-streptococcal nephritis and the other nephritides indicate. And hope this knowledge will help you in your subsequent management of patients once you get onto your clinical work. Thank you.